Hi, it's Dr. Lau again, and for this learning topic, we'll be going over renal blood flow, GFR, glomerular filtration rate, and clearance. So we're talking about how urine basically is going to be filtered from blood into the Bowman space. So the very first step is getting through this very sophisticated glomerular filtration barrier. And this ultrafiltrate from the glomerulus is then going to move along the nephron or the lumen of the kidney tubules to form the final urine. So the glomerulus, just think of it as a tuft of very specialized blood capillaries. So you have the afferent arteriole going in to form this loop of capillary vessel, and then the efferent arteriole exits from the glomerulus, and the filtrate that comes through the specialized filtration barrier goes into the Bowman space of the Bowman's capsule. And then it's going to be moving along the proximal convoluted tubule to the loop of Henle to the distal convoluted tubule, and then the collecting duct. And then finally, the final urine product flows into the papillae, down to the ureter, and into the bladder. And the kidneys, even though they're about 0.5% of the total body weight of an individual, it receives about 25% of total cardiac output. So the kidneys are seeing a lot of blood flow per minute, 1 to 1.25 liters per minute of blood, because cardiac output is about 5 liters per minute. So really, when you think about each glomerulus being a very specialized blood capillary, you know, the kidneys are essentially a bunch of blood vessels, and it's no surprise that they're receiving so much blood flow because they have to process out toxins and excess water, and maintain the homeostasis of the body. So what determines blood flow is the driving pressure, which is the difference between your renal artery and your renal vein, the difference in the blood pressure. And then you divide that by the resistance in this setup in the nephron. And when you calculate out how much blood flow is getting through the system, the kidneys are processing the entire blood plasma more than 10 times per day. So they are so critical to, again, maintaining the homeostasis and health of the body. So where does the resistance come in? The main players in determining resistance are the afferent and efferent arterioles. And the afferent arteriole is, of course, regulating the blood pressure entering into the glomerular capillaries. And then the efferent arteriole on the back end provides a back pressure, depending on how constricted down the vessel is, provides that back pressure resistance to maintain the glomerular blood pressure. And the glomerular capillary blood pressure, you may hear it referred to as hydrostatic blood pressure. Sometimes they'll have this abbreviation, pressure GC, pressure of the glomerular capillary. And the normal range is about 50 to 60 millimeters of mercury. If you visualize it, you know, as the blood is coming from the renal artery and going down to interlobular artery and getting down smaller to the arcuate, and then interlobular arteries. When it gets to the afferent arteriole, this is where you see a major drop in the blood pressure between the interlobular artery to the glomerular capillary network, because we're trying to protect this very delicate capillary system, which is so important in filtering out toxins and waste products. So the afferent arteriole really, you know, regulates this blood pressure that is hitting the glomerulus. And then when you get to the efferent arteriole, there's a further drop in the blood pressure going through. such that when you get to the veins, the blood pressure is much lower, because we know the venous system is less distensible and cannot handle higher blood pressures. So this important glomerular filtration barrier has three components. On the right here is an electron microscopy image of if you section through a glomerular barrier, you'll see that there's this layer down here, the darker cell processes. And then the middle layer is your glomerular basement membrane. And then this outer layer with these interesting humps is the podocytes, very specialized epithelial cells. So when they draw it out in a cartoon schematic, again, this inner layer is the fenestrations between your endothelial cells. So this is your blood compartment side of the capillary network. So endothelial cell of the blood vessel, and then this glomerular basement membrane, and then the filtration slit and podocyte foot processes on the outside. And then on this end is the Bowman space, or where the urinary filtrate is going through. So the starting inner layer, the capillary endothelium, it has a negatively charged glycocalyx. So basically you're trying to repel proteins which are negatively charged, because you want to keep the important stuff in your bloodstream, right? Like your nutrients and your antibodies and your proteins. You don't want that leaking out into the urine. So this negative charge glycocalyx helps to repel and keep the good nutrients and proteins in the blood and not having it leak out. So that first barrier part is the capillary endothelium. And then the next component is your glomerular basement membrane, which is made of collagen, laminin, proteoglycans. Again, very important for not allowing bigger molecules to pass through, but getting rid of the smaller molecules, waste products. And then the urinary filtrate finally, before it gets out there, it has to get through the podocytes. So the podocytes, again, are the very specialized epithelial cells. And I'll show you a 3D schematic because it's kind of sometimes hard to imagine it when you look at a 2D section. But the slit diaphragms are very highly negative charged, and they're also very narrow. So they select out and block substances from moving out of the bloodstream based on size and charge. And then here's nice scanning electron microscopy images. So you get a visual of this all happening in 3D, right? So the glomerulus, again, is this little tuft of the capillary blood vessel kind of coiled around itself. And then around the glomerulus are these specialized epithelial cells, the podocytes. And here they just arbitrarily assigned this cell as a purple, this cell is in green, but they have these very amazing foot processes that are extending from the cell body. And these foot processes are interdigitating and forming again the slit pores through which the urine has to the plasma has to filter out in order to form urine. So in a healthy individual, healthy kidney, you should see intact podocyte foot processes when you look at a transmission electron microscopy image. So these foot processes are very clear, and there's the slit pore in between each of them. But when you have a diseased kidney that's affecting the podocytes, you get loss of these nice foot processes. So we call this effacement. So now these foot processes are kind of muddled. You don't get that nice slit pore, and now substances from the blood are going to leak into the urine. So in terms of what gets through this sophisticated glomerular barrier, anything smaller than 7,000 Daltons or 7 kilodaltons, they'll freely filter through. So water, sodium, urea, glucose, their molecular weight are all under 7,000 Daltons. They'll filter right through into the Bowman space. And then as you get from 7 to 70 kilodaltons, you'll see that the filtration drops off dramatically. Albumin is around 70 kilodaltons and is kind of taken as that cutoff point where you shouldn't see bigger proteins leaking through if your glomerular barrier is intact and healthy. So a little bit gets through, 0.02% of serum albumin gets through into the Bowman space. But most of this albumin is quickly reabsorbed by endocytosis in the proximal tubule. So most of the time, there's very little that you should detect, or even zero that you'll detect on the urine test or urinalysis. So now that we understand this barrier in the glomerulus, we can understand that if we're detecting protein in the urine, that's not good. That's indicating, injury to the glomerular filtration barrier. Because really, your blood cells, your white blood cells, red blood cells, your proteins, your, again, antibodies, hormones, nutrients, should be staying in the blood. You don't want to be losing that in the urine. So normal urine protein excretion is less than 150 milligrams per day, and normal urine albumin loss is less than 30 milligrams per day. And we actually have categories that you'll see when we're working up patients in terms of how we categorize how much albumin they're losing in their urine. So if someone's losing 30 to 300 milligrams per day of albumin in the urine, we call it microalbuminuria. And if it's above 300 milligrams per day, it becomes macroalbuminuria. And it's just more concerning for more severe kidney disease. And the ratios here, don't worry about it too much for now. We'll explain more in a later learning topic. We sometimes use spot urine testing to estimate how much albumin is in the urine. And we normalize it to gram of creatinine in the urine, which is why the units is milligram per gram. This is based on an assumption that each person is excreting 1 gram per day of creatinine in the urine. And then for more accurate quantification, you might have someone do a 24-hour urine collection, and then you can really measure how many milligrams of albumin are being lost per day in that 24-hour urine collection. But the spot urine testing gives us very nice estimates and is much less cumbersome for the patient. They don't have to collect 24 hours of urine. So what are the types of protein you might see in a urine test? If you took someone's urine and you sent it to the lab for analysis, the most abundant urine protein in mammals is TAM horsefall protein. It's produced in the renal tubular cells in the distal loop of Henle, probably has a role in maintaining health and excretion of toxins by the kidneys. And then glomerular proteinuria is when we're detecting increased filtration of macromolecules across the injured glomerular barrier. And then we call tubular proteinuria is when we see increased low molecular weight proteins coming out in the urine, like your immunoglobulin antibodies. Those would be low molecular weight proteins. And tubular proteinuria, if it's increased in a patient, it could indicate impaired tubular reabsorption. So it could be tubulointerstitial disease intrinsic in the kidney, or it could be happening because of what we call overflow proteinuria. This can be in multiple myeloma, for example, when they're overproducing antibodies from proliferation of lymphocytes, and then the kidney filtration system is overwhelmed, and you'll see overflow of low molecular weight antibodies into the urine. Tubular proteinuria can also happen, for example, or overflow proteinuria can happen with rhabdomyolysis. So if you have excessive muscle breakdown releasing myoglobin, that myoglobin protein will show up in the urine and be detected as tubular proteinuria. So understanding the type of protein coming through gives you a hint at the disease that's going on. So again, if you see albumin, then we know, because it's a large macromolecule, more albumin in the urine is telling us there's injury to that glomerular filtration barrier. So what's the relationship between renal plasma flow, renal blood flow, glomerular filtration rate? So here are some definitions. Renal blood flow, again, is how much blood flow the kidneys are seeing from the heart. So they're getting 20 to 25% of cardiac output, which works out to 1 to 1.25 liters per minute. Hematocrit is how much of your blood volume is blood cells, right? Because you're circulating blood, that's the blood cells, and then that's the plasma water. So hematocrit is typically 40 to 45%. So your plasma component of your blood is going to be 1 minus hematocrit. So 1 minus your blood cells. So plasma is 55 to 60% of your blood flow. Or when you're doing calculations, this is 0.55 to 0.6. And then renal plasma flow is going to be 1 minus your hematocrit, which is, again, your plasma, multiplied by your renal blood flow. So typical values, if you take 1 minus 0.4 hematocrit, this is going to be 0.6 liters per minute, assuming a 1 liter per minute renal blood flow. So again, it's just taking 1 minus hematocrit multiplied by your renal blood flow. So renal plasma flow is usually around 600 mLs per minute. Your glomerular filtration rate, so what's actually passing through that filtration barrier, is 125 mLs per minute in a healthy individual. Probably when we're born, GFR is around 150, and then we kind of all gradually lose GFR as we age, and that's just normal aging. And then if you look at the filtration fraction, you're just taking your GFR and you're dividing it by your renal plasma flow. So 125 divided by 600 gives you 0.21. So translating that into a description, that means about 20% of your plasma flow getting to the glomerular capillaries is then filtered into the Bowman space to form the initial urine filtrate. So what are the 4 Starling forces that determine glomerular filtration rate? So there are forces that promote filtration into the Bowman space to form the urine, and there are forces that oppose filtration into the Bowman space. So the most important force, of course, is the blood pressure getting to the glomerular capillary, and that's the pressure GC, PGC, pressure of the glomerular capillary hydrostatic pressure. And then if you think about colloid oncotic pressure, so any proteins, macromolecules in the space is going to be drawing fluid in, promoting fluid into that space where that colloid is. So theoretically, if there is proteins in the Bowman space, that's indicated with this pi symbol. So colloid oncotic pressure in the Bowman space, pi BS, that's going to be also drawing fluid into Bowman space. However, this is considered to be 0 for this component because the urinary filtrate is essentially protein-free, in a healthy individual where the glomerular barrier is intact. You should not be losing proteins into the Bowman space. And then what is opposing filtration is going to be hydrostatic pressure in Bowman space. So that's pressure BS, pressure of the Bowman space. And then the colloid pressure in the glomerular capillary side in the endothelial space. So that's going to be pi GC, which is colloid oncotic pressure of the glomerular capillary. So in a visual schematic, so here's your pressure of the glomerular capillary that's pushing fluid from blood into Bowman space to form the urinary filtrate. You have the opposing force of the oncotic colloid pressure in the blood space that's kind of pulling fluid more back into the bloodstream. And then you have the pressure from the Bowman's capsule or Bowman's space, the hydrostatic pressure that's pushing fluid also back toward the blood space. And we don't see the colloid oncotic pressure for Bowman space because that's essentially 0. There shouldn't be proteins on this end. So then your net filtration pressure, if you plug in all the values, again, you don't have to memorize these numbers, but the net filtration pressure ends up being around 17 millimeters of mercury that's forming the urine filtrate. And then amazingly, because the kidneys are very amazing, 99% of the urine filtered is reabsorbed, because of course, if we're losing all this filtrate every minute, we're going to need to be constantly eating and drinking to replace all these nutrients and volume. So normal GFR, 125 mLs per minute. If you multiply that 60 minutes per hour, that's 7.5 liters per hour, multiplied by 24 hours in a day, you are filtering 180 liters per day in the kidneys. And typical urine output is 2 liters a day. So if you do simple math, 2 divided by 180, about 1% of this filtrate getting through the glomeruli are being excreted as urine. So 99% of the filtrate is reabsorbed. And to maintain a constant GFR through the day, whether you're sleeping or you're running a marathon, autoregulation is really important to maintain GFR. And this keeps a renal perfusion pressure between 80 to 180 millimeters of mercury. So the auto-regulation mechanisms really are at the level of the afferent arteriole. So that arteriole that's going in and forming that glomerular capillary tuft. So if there is an increase in renal perfusion pressure, if there's a spike in blood pressure or blood volume, this is sensed by the afferent arteriole in 2 ways. So the myogenic reflex kicks in very quickly within 8 to 10 seconds, because the change in luminal pressure is sensed by stretch receptors. And in response to this, the vascular smooth muscle cells in the arterial wall will constrict. And then there's also a tubulo-glomerular feedback that's also, again, very sophisticated, that takes 10 to 30 seconds to kick in. And the goal is, again, when there's a spike or as blood pressure increases, your diameter of your afferent arteriole is going to get smaller, so that you maintain renal blood flow and perfusion in this very steady flow rate, 1 to 1.25 liters per minute. So you can imagine when people present with hypertensive urgency and their blood pressure is 200, the autoregulation of the afferent arteriole is overwhelmed, and now you have higher pressures hitting your glomeruli, and you could cause injury. And that's why at very high blood pressures, you can see protein and some blood detected in the urine because of the injury that is happening. So let's delve more into the juxtaglomerular or JG apparatus. This has 3 main components. That's the juxtaglomerular cells, and in the figure down here in the corner, these are the cells lining the afferent arteriole here, denoted in C as part C in the caption. And these JG cells contain renin, which is a proteolytic enzyme. When there's a decrease in blood pressure, JG cells release renin. This causes hydrolysis of angiotensinogen to angiotensin 1, which is then further converted by angiotensin converting enzyme, primarily in the lungs, to angiotensin 2. And this causes vasoconstriction of systemic arteries in order to raise blood pressure. There are also some JG cells in the efferent arteriole, but it's thought that the main mediators of the JG response is from the afferent arteriole cells. Then the next type of cells important for the JG feedback is macula densa cells. And this is denoted as B in the figure, this histology figure. So these are specialized columnar cells found in the late part of the thick ascending loop of Henle and also in the early distal convoluted tubule. But essentially, these are specialized cells in the more distal part of the nephron, and they work to sense sodium concentrations in the urine in the distal part of the nephrons. And this is important because they will release specific factors, paracrine factors, in response to high or low sodium levels in the urine. Paracrine means, releasing hormones that are acting at the site where the hormone is produced. And you may have heard of the term endocrine. Endocrine is when hormones are released and they act systemically at other sites in the body. But we'll be discussing paracrine factors in this setting of the macula densa. And then finally, the third component of the juxtaglomerular apparatus are the mesangial cells, denoted as D within the glomerulus. And the mesangial cells basically are the link between the JG cells and the macula densa cells, and help to coordinate the physiological responses of the JG apparatus. So the goal of the JG apparatus, of course, is to maintain constant glomerular filtration rate. So in these two scenarios, if there's an increased renal blood flow, and again, we don't want to overload pressure on the glomerular capillaries by having too high a blood flow going through. But when there's increased renal blood flow, there's going to be increased sodium delivery to the distal nephron. So then the macula densa cells, when they sense this higher sodium concentration, they'll release ATP or adenosine. And this will induce constriction of the afferent arteriole to decrease the glomerular pressure, the pressure of the glomerular capillaries. And this ATP and adenosine paracrine factors will also decrease renin from the JG cells. Conversely, if there's a decrease in renal blood flow and this decreased distal nephron sodium concentrations, macula densa cells will release nitric oxide, prostaglandins, and these will induce dilation of the afferent arteriole to increase the blood flow that's hitting the glomeruli. And then it will also increase renin from the JG cells to downstream lead to increasing systemic blood pressure. So moving on to renal clearance, the definition of renal clearance is the volume of plasma from which a substance has been removed by the kidneys per unit time. So per unit time can be per minute, per hour, or per day. And then volume we typically think of as in liters. And the clearance depends on the filtered load, secretion rate by the tubules, reabsorption rate by the tubules, and if there's any metabolism or degradation by the tubule cells. Please memorize this formula for clearance, and we actually do use it in clinical management of our patients. We use it to calculate as one way to calculate their kidney function from 24-hour urine studies. We use it when we're calculating dialysis prescription to see how much clearance we're getting from the dialysis modality. But you'll hear UV over P. That is the fundamental equation. Clearance is UV over P. So U is the urine concentration of the substance of interest, for example, creatinine or urea. And then you multiply by V, which is your urine flow rate, which is usually mLs per minute. And you're going to divide that by your plasma concentration of the substance. So excretion rate divided by plasma concentration. And again, we're talking about volume of a substance that's cleared per unit time from the plasma. Of course, in reality, this is all a bit of a hypothetical because you're not going to get an exact volume of plasma that's completely cleared of a substance per unit time because there's continuous blood flow. So your entire plasma is just getting partially cleared of a toxin minute by minute. But really it's a dynamic process. So you can't have like this volume is like exactly voided of a toxin per unit time. So talking again about those major factors that determine clearance, number one, of course, how much is filtered out, and the filtration happens only at the level of the glomerular filtration barrier. And then reabsorption happens in the tubules as it's going along, as the urine is moving along the nephron. Secretion happens from the peritubular capillaries that surround the tubule because further elimination of the toxin is moving from the blood into the urine space from the peritubular capillaries. So whatever of the toxin did not filter out here, it's going to go through the efferent arteriole and it's going through the peritubular capillaries. And there might be mechanisms in place for more of it to get secreted into the urine space. So some route of elimination is happening there. And then finally, after going through all the steps and going through the nephron, you're going to have your final urine product, which is then excreted and eliminated from the body. And that can be expressed as ml per minute or per hour or per day. So in summary, excretion is your sum of filtration plus secretion minus any reabsorption that happened in the tubules. So let's do an example, ciprofloxacin antibiotic. So when you give someone a dose of oral Cipro, approximately 50% is excreted in the urine as unchanged drug. That's why Cipro is helpful for treating bladder infections, UTIs, because it's getting into the urine to kill the bacteria. And then after 24 hours, pretty much all the Cipro would have been excreted into the urine. When you calculate actual renal clearance, if you go and test the individual's urine, you'll realize that renal clearance of Cipro is 300 mLs per minute, whereas normal GFR, again, is around 120 to 125 mLs per minute. So how is this happening? So they give you 3 options here in a multiple choice scenario. And the answer here is that Cipro is being secreted into the renal tube, or by the epithelial tubular cells into the urine filtrate. So it's filtered and then there's secretion happening. So whenever clearance is greater than your GFR, the take-home point is there is secretion of the substance happening directly from the tubule into the lumen space. The other options were incorrect because your filtration fraction cannot ever be higher than plasma filtration rate because there's no active transport in the glomerulus. It's just pure filtering out. And then reabsorption of water, should not change the quantity of the substance that's being cleared. It's either going to be more concentrated or less concentrated, but the clearance is not going to change per minute. So there's been, a lot of work over the years as to using substances that can help us calculate someone's glomerular filtration rate and estimate their kidney function. So ideally, we want to use a substance that's freely filtered. It's not being secreted by the renal tubular cells. It's not being reabsorbed by the peritubular capillaries. And it's not being metabolized by the kidney. So there is actually a substance that meets these requirements, which is inulin. It's a polymer of fructose. So very small substance, 5.2 kilodaltons, so 5,200 daltons. So it's not secreted, it's not reabsorbed in the renal tubule. So if you imagine that the plasma concentration of inulin is 1 milligram per mil, and what's coming out in the urine is 125 milligram per mil, and the urine flow rate is 1 mil per minute. And if you plug in these numbers, you'll see that it estimates GFR 125 mils per minute. However, this is very cumbersome for using in patients. It's done in research studies, but not for routine patient care, because you have to infuse IV inulin over several hours to get a stable plasma concentration, and then you have to keep sampling their urine and calculate out the GFR. So everyone's very familiar, of course, with creatinine. Creatinine is measured on routine metabolic panels. It's a small molecule as well. Molecular weight is 113 daltons. It's produced from muscle turnover, just normal muscle metabolism, and serum creatinine is relatively constant. The caveat to using creatinine to estimate GFR is there is some tubular secretion of creatinine, which accounts for about 10% of total creatinine clearance by the kidneys. So just bear in mind that if you're using a 24-hour urine collection to calculate creatinine clearance, this value is going to overestimate the person's actual GFR because of this secretion by the tubules. So instead of having to calculate from 24-hour urine, there's been a lot of work that has developed sophisticated equations to estimate GFR just from sampling a patient's creatinine on a blood test. So if you did a basic metabolic panel or a comprehensive metabolic panel, there's always creatinine on there, and you can have that estimated GFR that's reported out. Don't memorize this slide. This is just to give you a comparison of all these equations that have come out over time. Of course, Cockcroft-Gault was the standard for a while. It was developed in a very non-diverse population, white males, young, or well, I guess it had a good range, young to old. So they were able to adjust for age, for weight. There was a correction factor for female sex. There was no adjustment for race. And then the modification of diet in renal disease, the MDRD formula, came out in 1999. Again, predominantly white population. And then this one had a race correction factor. And then CKD-EPI equations came out in 2009, 2021. The most recent formula does not account for race. So this was actually a big controversial thing that came out in the past couple years, that it was not biologically valid to be correcting for race. And the concern was that correcting for Black race was actually leading to underdiagnosis of kidney disease in the Black population and leading them to come to medical care later. So their diagnosis was essentially being delayed. So because of that, there's been a huge move across medical centers and clinical labs to remove that age adjustment, or rather the race adjustment. So a few years back, if you looked in our clinical lab reporting, they would always report 2 GFR values, eGFR. So there was an eGFR, and then there was a African-American eGFR reported out. And this was eliminated a couple of years ago. So now we do not have race adjustment, which is more appropriate for making sure there's equity and access to care when evaluating for kidney disease. So, and just keep in mind that creatinine is very insensitive at the high GFR levels. So when your creatinine is less than 1, your GFR could have shifted anywhere between 150 to 90 or 80, and it would not be sensitive to picking this up. But of course, this is as expected, a reciprocal relationship, because the higher your creatinine is in the blood, it means your kidneys are not eliminating toxins and your GFR is going down. A newer marker that we have available at the UCI Medical Center lab is cystatin C. So this is a table just comparing the 2 markers, and each marker has its own limitations. So creatinine, again, it's from muscle turnover. It's freely filtered. There's some tubular secretion. It really doesn't pick up on decreased eGFR until you've lost maybe half your GFR already. And then modifying factors, if someone is a bodybuilder, has a high muscle mass, creatinine is going to look higher, and it doesn't mean that their kidney function necessarily is decreased. If someone's taking a lot of protein and drinking shakes, protein shakes to, I don't know, again, maybe build muscle or avoid carbs, that's going to make the serum creatinine look higher as well. And then some medications, so we know that ACE inhibitors, angiotensin receptor blockers, because they're regulating relaxation of the afferent and efferent arterioles, is going to regulate renal blood flow and sometimes cause creatinine to bump up a little bit. This is something we often have to explain to patients. It's a protective mechanism. Please don't worry if your creatinine bumps a bit when you're starting an ACE inhibitor or angiotensin receptor blocker. We know in the long term is protective. A common antibiotic, Bactrim, actually inhibits tubular secretion of creatinine, so that can make the eGFR again, look a bit lower when someone's starting Bactrim. So those are the things that can modify creatinine eGFR. In terms of cystatin C, it's produced by all nucleated cells in the body. It's freely filtered, and actually, interestingly, it undergoes degradation in the tubular epithelial cells. So you can't detect cystatin C in the urine. So you cannot do a 24-hour urine collection for cystatin C. You're not going to measure anything. It is more precise and accurate, the serum cystatin C, more accurate than creatinine. However, it is modulated by inflammation, cancer, thyroid disease. So these entities can make creatinine appear higher, cystatin C appear higher, and that's going to make your GFR look a bit lower than it actually is. So it's actually nice to have both. I like measuring both. It gives me, two markers and more information on the estimated GFR of an individual without having to do a 24-hour urine collection. So then clearance ratio, it's a comparison of the clearance of a substance divided by the glomerular filtration rate. And this gives you some information about how the kidney is processing that substance. So for example, glucose has a clearance ratio of 0 because it is freely filtered, but then it's completely reabsorbed, mainly in the proximal convoluted tubule. So clearance ratio is 0 for substances that are completely reabsorbed. If the substance is freely filtered and then partially reabsorbed, your clearance ratio is going to be between 0 to 1. For inulin, which is freely filtered, not reabsorbed, not secreted, your clearance ratio is 1. It's estimating GFR. And then if it's filtered and it's also secreted, then of course your ratio is greater than 1. So anytime you see a clearance ratio above 1, there is tubular secretion going on for that substance. And then this is again what people have utilized more in research settings, but you could actually use a substance to measure renal blood flow. We're actually referring to effective renal blood flow because it's not really true renal blood flow because there's always a small amount that's remaining in the renal vein for all substances. Because if you wanted to really measure true renal blood flow, all of the substance is removed and the concentration in the renal vein should be 0, but that's not going to happen in reality. So, so we can use it to measure ERBF, effective renal blood flow. So para-aminohippuric acid, PAH, is freely filtered and then fully secreted. So whatever wasn't filtered at the glomerulus, the remaining 80%, is fully secreted out by the tubules into the urine filtrate. So again, the same UV over P calculation, if you use these numbers from this diagram, the PAH clearance calculates out to 585 mils per minute, which is your effective renal plasma flow, ERPF. And then if you recall from the earlier slide, renal plasma flow is 1 minus hematocrit multiplied by the renal blood flow that's hitting the kidneys from the heart. So if we rearrange this equation, you can calculate renal plasma flow, which is, calculate renal blood flow or effective ERBF. So that's going to be your renal plasma flow divided by your 1 minus hematocrit, and this comes out to about 1.1 liters per minute, which is accurate since we know the kidneys are receiving 1 to 1.25 liters per minute from the cardiac output. So again, we're calling it effective. You see the E, effective renal plasma flow, and effective renal blood flow, because this is what we can measure using these substances, but it's not true renal plasma flow and renal blood flow because you're not hitting a venous concentration of 0 at the end after the blood has gone through the renal system. In nuclear medicine scans that we do use in patients to estimate kidney function, or mostly used in, again, research settings, they have newer agents that use iodine-tagged OIH and technetium-tagged MAG3. Don't memorize these names. It's just to let you understand that there are other substances aside from PAH that are freely filtered and fully secreted, so they can be used to estimate renal plasma flow. And so in summary, these are the items that were reviewed in this topic of renal blood flow, GFR, and clearance. Do pay attention to some of these equations that we went over, including renal blood flow, how to calculate renal plasma flow, and be aware of the clearance equation, UV over P. And these will be also listed in the renal review document.